What you can't sense from TV, again, is the size of the disaster, but also the sounds and the smells.
It was just destruction everywhere, just buildings flattened. I'd never seen, you only see it on the movies, it just did not look real at all.
You know, your heart has to go out to the Haitian people.
Even after having seen Haiti on the news, I think it was just astounding how bad the city was.
It exceeded anything I had ever experienced in my life in trauma.
While Katrina was a massive disaster, one of the worst in our country, it pales in terms of the loss of life. We lost 2,000 lives in Katrina. It's now estimated that 230,000 lives have been lost in Haiti.
We were, of course, contacted very early on, contemplating the activation of the mobile field hospital. Unfortunately, when that didn't happen, fortunately, we already had put a team together because we knew we would respond if it was mobilized.
I know of no organization that has their own team, funded by their own organization, that can respond both locally and now internationally in the event of a disaster. We've made a lot of contacts with the federal government, with John Bardis at Med Assets, who provides our general purchasing support. He was flying in teams already to Haiti in his private jet, and we decided to send in a team.
Nuncio extended his hospitality to Chris and me that first week. Ed Gamboa met us at the airport at 3 a.m. in an armored SUV with a police driver with diplomatic license plates. And that was the beginning, I think, really of a perfect partnership for us to do what we were trained and prepared to do.
We flew in with a group of physicians from Inova who were supporting some rural hospitals. Made contact with the papal nuncio through a former trauma surgeon at Scripps, and he picked us up at the airport and identified a hospital 1 mile from the epicenter that was virtually destroyed. Brent and I had a chance to operate together. It's actually the first time I've had a chance to watch him operate since he's been our chief medical officer for so many years. And we worked for a couple of days there, and then ultimately came home and prepared our team. Within the first hour, we asked Scripps for volunteers. Within the first hour, I think the disaster office received 700 emails with 1,000 volunteers.
Having Chris and Dr. Eastman go for the initial mission obviously was really, really helpful to those of us who ended up going on the second team, because we really did have a great preview of what the conditions that we were going to be living in, facing at the hospital. Obviously, we had all seen the pictures on the news, but even Chris's pictures that he sent back from the local environment of the city and the hospital were so much more personal and were so much more focused kind of from a healthcare perspective and our own environment perspective that really helped us to prepare.
We were able to provide patient care almost immediately because we had pre-plans. We also had practiced this, one with previous disasters that we've been involved with, but we practice it on a regular basis through our disaster management program.
Not only did the patients have horrible injuries with crushed extremities, broken bones through the skin, dead tissue, gangrenous feet, gangrenous toes. And we would ask them how they were injured, and that was important to know what, as a trauma surgeon, what was the mechanism of injury. Were you in a building and it came down on you? Were you hit by a collapsing wall? Were you in an automobile that got crushed? So we documented that. But then we also ask, did you lose family members? And I would say almost without exception, every patient that I personally interviewed and cared for had lost some or their entire family.
It was amazing the first day when they hit, when we got to the hospital, how quickly everything happened. A couple of us got the supplies lined up for the OR. The anesthesiologist quickly got the anesthesiologists who were at the hospital from the University of Maryland together. They did the cases together. They got moving very quickly. We all fell into roles and got some patient flow going, got the ORs going, and I think that that was pretty amazing.
Given the fact that there was no Home Depot or Walmart or grocery store that we could just, hey Rob, we need this, 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 and this. Okay, I'll be back in 30 minutes. There was none of that, so we had to improvise. And luckily the team, I don't think it was luck, I think it was planned. The team that went, the people were flexible. Everyone left their egos at home long before we even showed up to pack all of our equipment. Didn't matter what the title was. Everyone was pitching in and doing everything.
We went in and we did assessments in the tent and saw what needed to be done, assessed the patients that should go to the OR first, and got them prepared for surgery that first day. And then on the second day, we really organized the hospital, identifying the patients, giving them all a number, walking around to all the different wards and assigning a patient number, getting everything organized.
I would run the OR board a couple of days, meaning get the cases scheduled, communicate with the docs, communicate with the triage clinic, figure out what cases should be going. We made a sort of a map, a census map of all the different wards, which is what we euphemistically called our tents, our hospital wards, and where patients were by their identification numbers. And then later, as we started to learn people's names, we would, be able to identify them by name and know where they were as we were bringing them back to the OR.
I had all anesthesia gear on my back with me, and we showed up and there was the team from Maryland, their advanced team, which was a nurse anesthetist, and she had come with her Lysol and her handy wipes to clean whatever equipment we could find there, and there was very little, of course. Then Dr. Shackford popped his head in the door and said, we have 8 very sick patients that need to be operated on today. And the nurse anesthetist and I looked at each other with our tank of oxygen and not much else, and luckily we had the, some equipment that I carried in, and we got to work.
We were cutting a cast off someone. My son, Wyatt, told me, Dad, make sure you take your Leatherman. So I took the Leatherman and we started using it to pry the cast apart. And then there's, I think, a couple of pictures of, Todd Austin and I doing a tug of war on each side of the cast. And then we got to the other, the fiberglass cast, and we did the same thing over again.
We ended up operating on Jean Candu several times. We think we saved his arm. We don't know whether his leg ultimately had to be amputated or not. Nuncio, when walking up to the bed, I told Nuncio, this is my favorite patient, because I'd operated on him more than anybody, and he was a very, very lovely man. And so Nuncio said, Dr. Eastman wants you to know you're his favorite patient, in Creole. And in Creole, Jean Candu said to Nuncio, tell him I like him too. And I had this flashback to patient satisfaction and all these scores and all this public reporting we do, and I thought, that is the greatest attribute personally of patient satisfaction I think I've ever had.
It was about midweek. You'd really gotten in the swing of things, and the wind had shifted, and I got the very faint but very distinct smell of death, and I looked up and I just caught the corner of the building that stuck out between the tent and the other hospital building. And written up there said PEDS, you know, for peds. And again, you kind of get slapped in the face with the real tragedy of the situation there.
Well, we clearly provided great care, great compassion for people in a small country. I think the learnings we bring back make whatever money we put out, which hasn't been a lot at this point in time, more than worth it. Certainly the Board of Trustees has been very supportive. While Haiti is certainly not our core mission, the fact that we had resources and people that could help was a blessing.
We've left a footprint there with our work, and we need to continue that. Some of the lessons learned have been significant, and one again is recreating the process in bringing every aspect of our operations at Scripps together to deploy a team, from IS to security to pharmaceuticals, supply chain management, human resources, legal, and then nursing operations, and then physician participation. Every aspect of our operations was involved in deciding how, what, where, and who should be deploying to a Haiti response.
I think maybe one of the greatest lessons for us to bring back is the mental preparation and the mental attitude it takes to be functional in a disaster situation versus being functional when every tool and device and person you need is right there at your, beck and call.
People say, how could you go there not knowing, where the water's coming from, where this, where that? How can every day you don't know what's going to happen? I'm going, well, how can you wake up every morning knowing everything that's going to happen? So I love that. It was a challenge.
It's definitely something that will be a part of my life. It was life-changing to see that level of humanity and that level of need, and to be able to be part of a medical response, because that makes you realize that's why we went into nursing. It's really the ability to provide that care to people in need.
It's hard to even verbalize and put it into words how much I learned. I'm so grateful for what I have, and it just makes me want to do more and continue to volunteer and just to grow in my own career, to be able to give back more when I go back in future years, because I know I'll go back.
What we have to do is not just amputations and fasciotomies and skin grafts, but once we get through that, we hopefully will be part of what I believe it's going to take the world, I think the magnitude of the problem, to rebuild that country.